Hello everyone, my name is Professor April Demito, and this presentation is the Women's Health Midterm Review. Let's begin with postpartum psychosis. Now, what differentiates that from postpartum depression? Well, postpartum depression generally occurs about 2 weeks following the delivery of the baby. So it's not uncommon for women to have the baby blues and they feel tearful after the delivery of the baby, about 24 to 48 hours, but that doesn't last long. It goes away. It's hormonally induced, and they have no ongoing issues. Postpartum depression is different. This is an overwhelming feeling of sadness. Um, Depression usually kicks in about 2 weeks after the delivery of the baby. It can last for weeks or months. These patients don't typically have any feelings of hostility towards the baby. They distance themselves from the baby. If they're going to harm anything, they typically are going to harm themselves, not the baby. Postpartum psychosis is a little different. Postpartum psychosis can occur anywhere from right after the delivery of the baby up to several months following the delivery of the baby, and postpartum psychosis presents itself with a delusional state. So women who are experiencing postpartum psychosis are delusional. That's one of the things that sets it apart from the other conditions associated with postpartum delivery. All right, clinical best breast exam. Now there are you're going to find different standards with different organizations. American Cancer Society, ACOG, which is the professional organization of OB-GYNs. They all have different guidelines for clinical breast exam. And however, this screening here is for mammogram. Now, with a clinical breast exam, there are some patients that you would uh, refer to a higher level of care. Those who were suspicious for um, breast cancer, so those with an inverted nipple. Now, if people are born with inverted nipples, they've always had inverted nipples their whole life, it's not an issue. But if something just now becomes inverted, that's concerning. Puckering of one breast, any masses. And remember, these things are typically, breast cancers are typically found in the tail of Spence. They are firm, fixed nodules. Um, Breast cancers are not typically soft and squishy, but these are all things that you're going to be looking for in your clinical breast exam. Ovulation. Now, ovulation typically occurs about day 14 of the cycle. That's going to be the fertile period, and this slide just illustrates where an ovulation occurs and the different hormone levels, how they are associated with the whole cycle of ovulation, but typically day 14. Perimenopause. Now, perimenopause can occur typically in the mid 40s. Mood changes, hot flashes. It can be very concerning. And often people in perimenopause have dysfunctional uterine bleeding. They may have periods that last extended periods of time, and that typically occurs because they may have months where they are anovulatory. What does that mean? They don't ovulate. Ovulation actually is a trigger for the body to turn off menstruation. If ovulation doesn't occur, then the other chemical mediators in the body kind of get confused and they don't know that they're supposed to shut off menstruation. But these can happen anywhere from typically begin about mid 40s. Okay, risks of teens. Now, patients who have disabilities are at risk for lots of things. And so we're talking about, in this course, women's health issues. Um, Women with disabilities are at a much greater risk of being obese. So, Down syndrome patients, we need to work with them to help keep their weight at an acceptable level for them because obesity triggers many other concerns now. High lipids, um, metabolic syndrome. So we want to work with these teens on keeping their BMI at a um, level that is appropriate for their age. Okay, adolescent reproductive assessment. Now, typically, we don't see a lot of teens coming into the office for reproductive assessments unless they're sexually active. Um, but something we're definitely going to assess is any menstrual issues. Um, Often, these teens come to the gynecologist because they are having extremely painful periods. They are having missed periods, irregular periods. So menstrual issues is typically the most common reason that teenagers seek attention from an OB-GYN, unless they want to go on birth control. The standard right now is that the patients are not required or not expected to have a pap smear until they're 21 years of age, whether they're sexually active or not. Menopause. We define menopause as the cessation of menses defined at the end of the first menstrual period. And menopause typically occurs in late 40s, early 50s. And you are not considered to be in menopause until you have been menstrual free for 1 calendar year. So you start counting at the end of the first menstrual period and then see how long you go before you get your period again. If it's a year, you're considered in menopause. If it's 4 months, then you have to start all over again. Metabolic syndrome is a concern for women going through menopause. Metabolic changes in bone, muscle, and fat decrease the bone and muscle mass. So we want to encourage menopausal patients to exercise. Walking, weight-bearing exercise is very important to keep that bone mass. High-protein diets. Someone is considered to have metabolic syndrome if their blood pressure is 138/86, elevated triglycerides, and a waist measurement that is beyond normal, so around 37. Those are components of metabolic syndrome. So we want to work. Metabolic syndrome is a precursor to diabetes, high cholesterol, hypertension. So we want to get that all under control, hopefully, to prevent those end-stage organ damage from occurring. All right, exercise in perimenopause. It's important for women to stay active throughout the lifespan, especially at perimenopause and through menopause. And the reason being is that metabolic changes, hormonal issues, women at this stage will find that it's a little more difficult to keep the weight off. They may gain a little more weight. And typically we recommend that if you are at a healthy BMI, 30 minutes of moderate intensity walking is adequate to maintain your current health state. Depression in women. Now this slide illustrates the differences in depression in men and women. Women are 70% more likely to be diagnosed with depression in their lifetime over men. And that being said, I think perhaps women are more likely to have a connection with their healthcare provider that allows them to be honest and open and discuss their depression perhaps. Men still have that umbrella of stigma where they may not be so forthcoming with their concerns regarding depression. I'm not quite sure, but women definitely discuss it more than men. Osteoporosis. Now, we want to try to prevent osteoporosis in our population, especially if there's a family history. So we want to encourage patients to eat vitamin D enriched foods, take calcium every day, and weight-bearing exercise. Those are the most helpful activities to help prevent osteoporosis from occurring. Leading causes of death in women. You may think, oh, it's going to be breast cancer, but the leading causes of cancer death in women is lung cancer, actually. So we really need to focus on smoking in women's health. We have considered smoking to be a man's issue, but it really isn't when lung cancer has taken over as far as the leading cause of cancer death in women, as opposed to breast cancer. So we need to encourage open conversations with our patients. Now, lipid screening in women. If you look at these charts, I found these and I thought they'll be helpful for you. This is one of those things that I would copy, paste, cut out, and put in a little notebook for future reference. So if I had a 35-year-old patient, I'm going to recommend that lipids be tested every 5 years on this patient. That is close enough and long enough to start treatment if we see that there's an elevation. So 35 years, doing a lipid profile test every 5 years is appropriate. Pap screening, and you can see here that a Pap screening is now recommended at 21 years of age. This is another one of those that I think is a great slide. I would take it, cut it out, put it in your little notebook so that you have that for future reference. The bimanual pelvic exam is when we are inserting our fingers into the vaginal canal and pressing on the abdomen. And we do this in examination so that we can identify any issues with the cervix, uterus, and the ovary. This is going to be an uncomfortable examination, but it should not be painful. So we're looking at those things. You know, if you take the cervix between your index and middle finger and move it around and causes a painful response, well, now I'm concerned the patient may have pelvic inflammatory disease. So there are many reasons we do the pelvic exam or the bimanual exam, but mainly we want to check the cervix, the uterus, and the ovary. Contraception. Okay. Different forms of contraception. Now, and when we're having our conversations with patients discussing contraception, we need to have an open door and explain and listen to all of their concerns. Now, if a patient has hypertension, smokes, we don't want to use birth control pills with estrogen and progesterone in them because that's going to cause a problem. So we really need to have a intimate conversation with our patients regarding birth control. For example, if a patient is Roman Catholic, strict Roman Catholic, they may not believe in birth control. But something that they can do is to abstain sexual intercourse during the time of ovulation. They may want to check their thermal temperature every day. Now, these are not reliable methods of birth control, okay? But it may be the only option for some people. So we need to keep an open mind. Preeclampsia, okay? So these are typically what we see with preeclampsia and the complications of maternal and fetal complications. Elevated blood pressure. Okay. Ectopic pregnancy. That's when fertilization takes place in the tube. And for all of you ED nurses out there, you may know that if a patient comes into the emergency department with severe abdominal pain, it's considered an ectopic pregnancy until proven otherwise. The reason being, a ruptured ectopic pregnancy can be life-threatening. So ectopic pregnancy. Chlamydia. This is one of the most common sexually transmitted infections that we see. It's treated with 1 gram of Zithromax, one-time dose. And the problem with chlamydia is that it can cause scar tissue to form and it can cause infertility. Unplanned pregnancy. And I think it's kind of interesting when you go back and you look at the statistics that about 50% of all pregnancies in the United States are unplanned. So that's kind of shocking. So education is so incredibly important. One of the problems with that is that young people have the tendency to not believe that this is going to happen to them, that they aren't going to get pregnant. They are in that denial stage. So we need to really educate. Vulvodynia, different types of vulvar pain. And it can cause irritation and burning of the vulva. It can happen to people who do repetitive sports like bicycle riding. So it's that continuous irritation of the vulva can cause that. Menopause and estrogen. So if we are going to check hormones on a patient and a patient comes in and they're presenting with some complaints of vaginal dryness, missed periods, let's check her estrogen level. And if she's in a postmenopausal patient, I would expect it to be less than 35, the estrogen level. So you can see this slide illustrates the differentiation of estrogen in patients and how once they get postmenopause, how that decreases. All right. All right. So this is an interesting concept here, this septa. The transverse vaginal septa. You can see what it looks like here, and it can cause a microperforation. So sometimes these patients present with abdominal cramping, pain, but no vaginal bleeding. And it's suspicious for this particular condition. So we would do a transverse ultrasound on these patients, transvaginal ultrasound on these patients to see what's going on. Bartholin's gland. These are glands on the outside of, well, actually the inside of the labia. They provide a lubrication that helps to prevent infection. Sometimes, though, they can become abscessed, and they're incredibly painful. The treatment is hot packs and soaking in a hot tub of water. These will typically cause these clogged Bartholin glands to burst, and the pain will dissipate. Vaginal intraepithelial neoplasia. So these are changes to the cervix that you're going to see. Most common cause of these neoplasias is HPV. So we want to encourage our young population to get immunized with the HPV vaccine starting at age 9, both boys and girls. Lichen sclerosis. This we see in the older population. And this is typically seen postmenopausal. It causes itching, irritation, burning. And this white area you can see on the picture. So that's suspicious for lichen sclerosis. Not a terribly uncommon condition in postmenopausal women. Endometriosis. Endometriosis can cause heavy periods, really severe pain during menstruation. And the reason being that this is uterine tissue. This uterine tissue becomes displaced in different areas. Now, during menstruation, contractions occur, right? Well, all of these little areas contract also. So that's what causes this increase in pain. a transvaginal ultrasound. This is how it's done. And it's a good way to examine a patient who presents with abnormal uterine bleeding. The reason being is that we can measure the thickness of the endometrium. And that measurement is going to tell us whether or not we need to biopsy in there to see. Remember, abnormal uterine bleeding is the #1 sign we see in people suspicious of uterine cancer. So transvaginal ultrasound is going to allow us to measure that epithelium in there to see whether or not we need to biopsy. Okay. All right. Premenstrual dysmorphic disorder is PMS to the nth degree. So these patients will have exaggerated symptoms of PMS. So they get excessive mood swings, cramping, anger issues. And after their period, they go back to themselves. And these patients are typically treated with serotonin uptake inhibitors, and these can be prescribed periodically. So people with PMDD may go on an SSRI. They may start it like a week before their period. They stay on it for 2 weeks and go off of it. So it's intermittent. They don't have to stay on it all the time. All right. Atriptan. Now, what do we use this for? Atriptan, and I don't know why we're talking about this in women's health, but I saw it noted. So we use this in patients who are experiencing migraines. So I guess that some patients experience migraines at an increased level when they are about to menstruate. So atriptan is one of the methods that we would use. All right. Pelvic organ prolapse. We see this in our postmenopausal women, usually in 60s and above. And this is actually the pelvic organs prolapse through the vagina, and it's graded. So have a good understanding of what the grade is. A stage 4 grade would be where it's actually coming out of the vaginal orifice. Trichomoniasis is typically a sexually transmitted infection. Now, the symptoms of this, I'm sure you've all seen this in your clinical groups. A frothy, mucopurulent yellow discharge with a foul odor. So those are the characteristics that we're going to see with that condition. Pelvic inflammatory disease. We worry about pelvic inflammatory disease mainly because of the risk of infertility because of this. But people with pelvic inflammatory disease, they can get sick. They can have fever, severe pelvic pain, adnexotenderness. Like I said, you do a vaginal exam and you wiggle the cervix, extreme pain. So these patients are high risk. HIV in women. Now, women are at an increased risk of getting HIV from men. And that being said, mainly because they have more mucous membrane exposed. So you think about how it is transmitted. It is bodily fluids, sexually transmitted through bodily fluids and blood. Now we have the vagina is very vascular. It's primarily composed of mucous membranes. So the diffusion of these fluids through the mucous membrane is much easier to transmit HIV to a woman than it is a woman transmitting it to a man, because men don't have the surface of mucous membranes that women do. Syphilis. Okay, so syphilis is a sexually transmitted disease, and typically it's treated with penicillin G injection. All right, hepatitis B. If a woman presents with hepatitis B, they have a 90% risk of transmitting it to the fetus. So what you're going to see when women test positive for hepatitis B, at delivery, they are going to be given a hepatitis B injection. not the immunization. They are given the antibodies immediately. Now, then in 24 hours, they will get the vaccine. That has a pretty good rate of reducing the transmission of hepatitis B. Galactorrhea. Galactorrhea is when patients present with a spontaneous discharge of milk from both breasts. This can happen in both men and women. What you're going to do is test the prolactin level. And if it's elevated, I'm going to then test further because pituitary tumors can cause this. Most of the time it's nothing, but we do need to check the prolactin level in these patients. Breast cancer screening guidelines. So clinical breast exam for young women. Actually, 20 to 39 every 1 to 3 years, and then over the age of 40 annual. That's ACOG recommendations. As I said, you're going to find different recommendations to different versions that you look at. I always go with the American College of OB-GYNs because they are the standard that all evidence-based material in the United States is considered. Okay. A fine needle aspiration. Typically, when patients present with cysts in the breast, cysts are fluid-filled. They're not tumors. They're not cancerous. Usually, they are resolved by fine needle aspiration. They just suck out the contents and that's it. External cephalic version. This is something I don't think they do too frequently nowadays. When I was in women's health, we had certain physicians that would do it. But if a woman presents with a breech position and really does not want a cesarean section, few physicians will take the risk of delivering a breech baby vaginally anymore. Just too much legal liability. A physician may try to do an external cephalic version. I've seen many of these done in my career, and they look like they hurt like holy heck. The thing is, if they're successful, they often are not, but if they are successful, you want to deliver the baby pretty soon after because babies have the tendency to be in that position because they like that position and they're going to flip back within a day or two. But that's what that's all about. Lochia. All right, so lochia is what we call the discharge that occurs following the delivery of the baby. So it's the vaginal discharge that occurs following the delivery of the baby. And it goes through different phases. It begins being red, and that's called lochia rubra. That lasts 1 to 3 days. Then on day 3 to 10, it becomes pinkish, and we call it lochia serosa. And then 10 to 14, white lochia alba. And it may actually last up to 6 weeks. Okay, that concludes the midterm review. I certainly hope that you find this helpful, and don't hesitate to reach out if you have any questions for me. Thank you.